Welcome back, future doctors and pathology enthusiasts, to Master Oral Pathology. Today, we're taking a full bench-to-chairside deep dive into a disease that has literally fascinated and honestly challenged healthcare professionals for centuries. We are tackling the oral pathology of leprosy, or as you'll often hear it called, Hansen's disease. This is an absolutely crucial topic. It's a perfect example of the crazy tug-of-war between an invading pathogen and our host immune system. Plus, let's be real, it is an incredibly high-yield topic for your dental board exams. So get comfortable, because we're going to master this whole shebang together.
To kick things off, let's start with a classic board-relevant question. Imagine you're sitting for your exams and you get hit with this. What is the most common cause of peripheral neuritis in the world? What instantly pops into your head? Is it diabetes? Maybe some obscure autoimmune neuropathy? Well, surprisingly enough, the answer is Hansen's disease, or leprosy. Crazy, right? Even today, this ancient infection affects a whopping 20 million people worldwide. That's a massive global health consideration. And understanding exactly how it damages those peripheral nerves is the absolute key to understanding its clinical presentation, especially right where we care about it most, in the head and neck.
Here's our quick game plan for today. First, etiology and pathogenesis. Second, clinical features. Third, histopathology under the microscope. Fourth, diagnosis and differentials. And finally, number 5, treatment and prognosis.
Section 1. Etiology and pathogenesis, the bacterial invaders.
Okay, let's dive right into this. To make sense of the clinical signs you're going to see in the dental chair, we first have to understand the quirks of the bacteria causing them. Hansen's disease is primarily caused by 2 bugs, Mycobacterium leprae and Mycobacterium lepromatosis. Now, underline this in your brain. These are acid-fast bacilli. That is a massive keyword for board prep. But here's where it gets kind of weird. These bacteria are notoriously difficult to culture in a standard lab setting. You can't just throw them on a petri dish. Instead, researchers literally have to grow them in the footpads of mice or in armadillos. Why on earth? Because these bacteria absolutely demand a low core body temperature to survive. And that temperature preference dictates exactly where they're going to attack the human body. Also, a quick myth buster. Leprosy is only moderately contagious. You're not going to catch it from a passing sneeze in the clinic hallway. It requires frequent, long-term direct contact or potentially heavy inoculation through the respiratory tract.
And once that exposure actually happens, the timeline is just staggering. We're not talking about a quick 48-hour incubation period like a common cold. No way. If a patient develops the tuberculoid form of leprosy, the incubation period can drag on for up to 5 years. And for the lepromatous form, it can take up to 12 years for symptoms to finally show up after that initial exposure. That massive difference in time is entirely dictated by the host's immune response, which beautifully sets the stage for the different clinical forms of the disease.
Section 2. Clinical features, the disease spectrum. This brings us perfectly to the clinical presentation. It's vital, and I mean absolutely vital, that you frame this disease in your mind as an immunological battleground, because the strength of your patient's immune system determines exactly what you'll see clinically. It's like a sliding scale. On one end, we've got tuberculoid leprosy. These patients have a robust, well-functioning immune system. Their cell-mediated immunity mounts this incredibly strong defense, effectively walling off the bacteria, and that results in a very limited, highly localized form of the disease. But on the exact opposite end of the spectrum, that's lepromatous leprosy. Here, the patient has a severely reduced cell-mediated immunity. The immune system just can't contain the bacilli, so the bacteria multiply and spread like wildfire, causing a generalized, systemic form of the disease. And as you'd probably guess, immunocompromised folks suffer a much more damaging, rapidly progressive course on this side of the spectrum. Remember how we just said these bacteria love the cold? They thrive below our core body temperature of 37 degrees Celsius. So naturally, they target the coolest parts of the body, our extremities, specifically the skin and peripheral nerves. Patients usually show up with cutaneous erythematous plaques or nodules. And as those bacteria invade the peripheral nerves, they cause deep anesthesia or numbness. Because the patient literally can't feel their extremities, they end up suffering repeated, unnoticed trauma, which leads to severe ulcerations and even bone resorption. So the crucial point for us is that oral lesions are primarily seen in that generalized lepromatous form, showing up in about 20% to 60% of those cases. Intraorally, you need to picture multiple necrotic ulcerated nodules. These take forever to heal and leave behind some really significant atrophic scarring. Over time, if this is left unchecked, that localized tissue destruction in the midphase leads to a pathognomonic presentation known as facies leprosa. If you hear that term on a board exam, your brain needs to instantly shout Hansen's disease. Let's break this down step by step. Facies leprosa represents severe maxillofacial deformity. Because the granulomatous inflammation aggressively targets the cooler, nasal, and maxillary regions, it outright destroys the anterior nasal spine and the anterior maxillary alveolus. The result? A very distinct collapsed midfacial profile caused by severe intranasal inflammation and major underlying bone loss. It is a devastating clinical outcome for sure, and it really highlights just how aggressive that lepromatous form can be.
Section 3. Histopathology under the microscope, the cellular battle.
So we've seen the gross clinical destruction. Now let's take a tissue biopsy and zoom in. What is actually happening at the microscopic level? Before we even talk about tissue architecture, you've got to memorize the specific stain used to catch these bacteria. Standard H&E staining, totally useless here for finding the organism itself. Because these mycobacteria have these thick, waxy cell walls, they are acid-fast. So the FITE stain, that's F-I-T-E, is an absolute must-know for pathology students. The FITE stain highlights those acid-fast bacilli as tiny, bright red rods, usually clustered super tightly right inside the cytoplasm of the host's macrophages.
And this brilliantly illustrates exactly how the clinical immune spectrum we talked about earlier translates directly into what you see in the biopsy. In the localized tuberculoid form, where the immune system is putting up a great fight, we see classic, well-formed granulomas that look remarkably similar to tuberculosis. You'll spot a really strong, highly organized presence of macrophages and epithelioid histiocytes effectively walling off the threat. But over in the generalized lepromatous form, the immune system is completely losing the battle. The granulomas are terribly formed. Actually, scratch that. They aren't really granulomas at all. Instead of neat immune walls, you just see massive, continuous sheets of macrophages absolutely stuffed full of bacteria. The bacterial load is just off the charts in this lepromatous tissue.
To quickly summarize the microscopic hallmarks for your study guides, you were looking for a general granulomatous inflammatory response. The predominant cells are your classic heavy hitters: macrophages, epithelioid histiocytes, and multinucleated giant cells. However, the true microscopic giveaway, the thing that separates this from other granulomatous diseases, is the specific infiltration of the small peripheral nerves by mononuclear inflammatory cells. That exact nerve infiltration is what directly causes the clinical numbness and all those subsequent traumatic injuries we talked about earlier.
Section 4. Diagnosis and Differentials, the clinical detective.
Okay, put your clinical detective hat on. You have a patient in your chair with necrotic oral nodules and maybe some midfacial bone destruction. How do we accurately diagnose this and rule out the mimics? First things first, diagnosis relies heavily on a solid patient history. You have to ask about long-term contact with known infected individuals or if they've lived in known endemic areas. And you absolutely must look beyond the mouth. Check for skin plaques, check for signs of peripheral nerve anesthesia in their hands or feet. As a dental professional, lock this golden rule into your brain. Finding oral lesions of leprosy without concurrent skin lesions is highly, highly improbable. Seriously, if you see oral nodules but their skin is perfectly clear, your diagnostic compass should probably point in a different direction. And finally, since there's no quick blood test for leprosy, a tissue biopsy is 100% mandatory to confirm the diagnosis.
Now, while we're waiting for that biopsy report to come back, we have to build our differential diagnosis. What else looks like this? Well, late-stage syphilis can cause palatal destruction, but a history of Treponema pallidum and totally different serology will separate that out. Sarcoidosis produces granulomas too, but they're classically non-case seating, and it affects a very different demographic. Lupus erythematosus might present with facial lesions, but you can easily rule that out with autoimmune markers, like a positive ANA test. Cutaneous leishmaniasis is another one, but that's a parasitic infection, so you'd specifically look for a history of vector-borne exposure, like sandfly bites. And of course, any aggressive oral ulcer requires you to rule out lymphomas and other neoplastic diseases. The biopsy will clear that up real quick by showing malignant cellular proliferation instead of an infectious granulomatous process. Section 5. Treatment and prognosis. Eradicating the threat. Let's move to our final step and see how all this builds into clinical management. Once our biopsy, complete with that FITE stain, confirms Mycobacterium leprae, what's the plan? Eradicating Hansen's disease is definitely not a quick fix. It requires a protracted, multi-year chemotherapeutic approach. We have to hit the bacteria with a multi-drug regimen to prevent them from developing resistance. For your exams, you absolutely need to know these frontline drugs: dapsone, rifampin, clofazine, and minocycline. Those are your mainstays. But getting rid of the bacteria is only half the battle.
As these bugs die off in droves, massive immune reactions can flare up, leading to severe inflammatory complications that can damage the nerves even further. So step 3 is crucial, managing those complications with powerful immunomodulators.
And this brings us to a really fascinating, honestly pretty surprising pharmacological twist. To manage those severe immune complications, clinicians often use thalidomide. Yes, that thalidomide. The notorious drug historically known as a severe teratogen that caused devastating limb deformities back in the mid-20th century. Today, thalidomide and its modern analogs like lenalidomide are carefully and powerfully leveraged for their incredible immunomodulatory properties. They are astonishingly effective at calming down the destructive inflammatory storms that happen during leprosy treatment. It's a crazy example of how a dangerous side effect in one context can literally become a life-saving mechanism in another.
Which leaves us with a final thought to ponder today. If a patient's own immune system strength completely dictates whether this ancient bacteria just causes a minor localized bump or widespread horrific destruction like fasces leprosa, how might the next generation of advanced immunomodulators completely revolutionize the way we treat this disease? It is a super fascinating area of ongoing research. Thank you so much for joining me for this Master of You Dental students. Keep studying hard, always trust your pathology, and I will see you next time on Master Oral Pathology.